E hoje, então, o nosso palestrante, Dr. Brennen McKenzie, é médico veterinário. Ele tem um blog que é Vet, em seguida a gente libera o link para todos acessarem. Ele é muito atuante no Twitter, debate com muita propriedade sobre Overdiagnosis e Overtreatment em medicina veterinária. E essa é a publicação dele, né, sobre tratamentos placebos para os nossos pets, né? E é extremamente interessante, ele fala com muita propriedade. Deixa eu interromper aqui minha tela. Dr. Brennen, thanks a lot for being with us today.
Thank you.
You can start, please.
Great, thank you. I'm looking forward to it. So I'm going to talk a little bit about evidence-based medicine in general and specifically about overdiagnosis and also about the role of placebos in veterinary medicine. These are things that it may surprise you to know are all common issues that both human and veterinary medicine share, though there are some interesting and important differences as well. Just a quick background as to who I am. I did my degree in veterinary medicine at the University of Pennsylvania. I work in small animal private practice in California at Adobe Animal Hospital, but I'm very interested in evidence-based medicine. I've been in the past president of the Evidence-Based Veterinary Medicine Association, trying to bring some of the practices and procedures developed in human medicine in the evidence-based field to veterinary medicine. A few years ago, I did a master's degree in epidemiology at the London School of Hygiene and Tropical Medicine, so I'm very interested in how epidemiology and the development of research knowledge fits into clinical practice in the veterinary field. And as Anna mentioned, I also have a blog known as the SkepVet, where I talk about a lot of issues, including alternative therapies as applied to veterinary patients. Evidence-based medicine is a set of tools that we've developed to deal with the way that human brains make associations and judgments and use evidence in making decisions clinically. And because veterinarians and physicians use the same tools, both domains are applicable to evidence-based medicine. So Dr. Crispleff has said that as a clinician, getting the right answer and picking the right therapy is less about the knowledge that you have, what you know, and it's more about understanding how you know things and how you think. If we understand how we make mistakes in judgment and in observation and decisions, we're going to do a better job as clinicians making the right choices for our patients. As most of you undoubtedly know, this is Dr. Sackett's sort of classic definition of evidence-based medicine, and I've highlighted a few pieces of this that I think are important. Evidence-based medicine requires a conscientious and explicit choice. We need to think about how we think and how we use evidence in order to use this method to help us correct errors. It involves integrating our clinical expertise and what we know as clinicians with controlled systematic research evidence. And this is true, again, in both the veterinary field and in human medicine. A subsidiary definition that adds one piece that I think was missing from Dr. Sackett's definition is that evidence-based medicine involves integrating both experience and research evidence with the values and the circumstances of our individual patients. We treat individuals, and the context of our treatment decisions will depend on those individuals. Now, veterinary medicine changes this a little bit in that our patients don't really have opinions or decisions to make about their care, but their owners, our clients, do. So we still have to interact with our clients' values and needs and goals in order to make decisions for our patients. You're all familiar, I'm sure, with one version or another of the evidence hierarchy, and this applies in veterinary medicine just as it does in human medicine. At the bottom, we have the easiest to use and most accessible form of evidence, which is just our opinions and our experience, but it's also the least reliable and the most subject to bias. And then at the top, we have synthetic evidence. We have systematic reviews and clinical practice guidelines. One major difference, as we'll see in a minute, between human medicine and veterinary medicine is that we have a lot less evidence at the upper levels of this pyramid. So we're often making decisions in the face of much less robust evidence than physicians are perhaps used to having. Vets are very positive about the general idea of evidence-based medicine. This comes from a survey that the Evidence-Based Veterinary Medicine Association did, where we asked people in veterinary medicine, what do you think about evidence-based medicine? And we got an overwhelmingly positive response. Unfortunately, veterinarians don't actually use evidence-based medicine in practice very much. This was a research study looking at how veterinary practitioners make clinical decisions. The concept of evidence-based medicine was never mentioned by any of the doctors in this survey, apart from occasionally mentioning that research seemed to be something that belonged in academia or in specialty centers and wasn't really important or used in general practice. So there's a big gap between our desire to practice in an evidence-based way and our actual day-to-day decision-making practices. So why is this? What's in our way? Why are we not able to practice in a more evidence-based way? I think there are a number of answers to that. They all come eventually back to this, to the human brain, to how we think about making decisions in clinical practice. I see a lot of veterinarians, when presented with the idea of evidence-based medicine, who give this response, which is essentially, I don't need research evidence. I have my clinical experience. I have done things and seen them work in my patients, whether it be alternative therapies like homeopathy or chiropractic, or conventional therapies, and I don't feel that I need research evidence to justify my practice. And this is still a fairly common attitude among veterinarians. We've had a hard time convincing them that their personal experiences are less reliable than controlled research evidence. We also have a tendency to rely on tradition or habit, what our mentors taught us to do or what history does. So in conventional medicine and in alternative medicine alike, we rely on the practices of the past. And it's difficult sometimes to change those practices even when new evidence comes along suggesting that they're not effective or safe. And finally, there's not a lot of drive from patients sometimes in human medicine, but also from clients in veterinary medicine to see us base our judgments and our practices on objective research evidence. Many of my clients are perfectly happy making their own judgments about therapies based on observing their pets. If they try a supplement or something that they picked up at the pet store and their pet seems better to them, that's good enough. Or if they hear an anecdote from a friend or a breeder, they're not as concerned about whether or not there's scientific support for the practices that they're using. And that makes it a little harder for us as veterinarians to challenge unscientific therapies and to bring evidence-based medicine into the clinic. And then, of course, we have all of the cognitive biases that work in the brains of both physicians and veterinarians alike. We tend to make decisions in ways that are complicated by the way that our brains process knowledge and make judgments. And this is true in the veterinary clinic as well as in the human hospital. Veterinarians also often lack training in evidence-based medicine. We don't talk about this in vet school, and we probably don't teach veterinarians enough about how to use this. Earlier, I showed you the response to the concept, which was very positive, but when you ask veterinarians, have you ever learned how to do a literature search or how to do a critical appraisal of a research paper, the vast majority of them have never had that training. So that's a barrier to practicing evidence-based medicine. If you ask veterinarians about common concepts in evidence-based medicine, you will find that many of them are unfamiliar with those concepts. What is the number needed to treat? What is a systematic review? What's the difference between relative risk and absolute risk? These are things that we're not often taught as veterinarians, and this impedes our ability to practice in an evidence-based way. And then finally, there is a dramatic lack of research evidence. In human medicine, it is fairly common to have multiple systematic reviews about a particular indication or therapy. In these examples of reviews that are published in veterinary medicine, the conclusions are very often that there simply isn't enough research to make decisions. So as veterinarians, even if we become interested in practicing in an evidence-based way, we're struggling with the lack of objective research evidence to base our clinical practices on. As an example of this, when I graduated from veterinary school in about the year 2000, there were a total of 15 systematic reviews in the entire veterinary literature. When this paper was published in 2011, that number had grown to 260. So there was definitely sign of improvement and growth in the amount of research evidence available. The most recent number I can find from 2018 shows about 600 systematic reviews in veterinary medicine. That's an improvement. But if you look at the Cochrane collaboration, which produces systematic reviews for physicians, at the same time, when that research paper was published in veterinary medicine, there were 5,700 Cochrane reviews. And as of last year, there were 7,500. So one organization alone is producing an order of magnitude more research evidence for physicians to use than is available to veterinarians. And this is a major barrier in evidence-based practice in the veterinary field. Finally, the quality of the research evidence we have to work with is often lacking. This comes from a research review that I did of 200 veterinary clinical trials. And what you'll see is that it's very difficult to assess the risk of bias in research studies because the reporting quality is very poor. We often don't design our studies effectively. We don't report our study methods effectively. It's difficult for veterinarians to know whether the research evidence that we read is trustworthy because we don't have a good system for developing and publishing research evidence the way it exists in the human field. And then finally, I would argue that veterinarians are not subject to the same sort of pressures that physicians often are that drive evidence-based practice. For one thing, there's a great deal less malpractice litigation in the United States. That's a major driver for physicians to stick with algorithms and guidelines put out by professional organizations because they're worried about being sued. That's not an issue for veterinarians very often in the US. There's very little government regulation and there's very little insurance in the veterinary field. So we're not subject to making decisions on the basis of reimbursement guidelines or any kind of professional standards. Individual veterinarians have a lot of freedom to choose the practices that they use. And this makes it easier for us to practice in an opinion or tradition-based way rather than an evidence-based way. So I want to look at a couple of examples of the interaction between evidence-based medicine and veterinary medicine and how it both is similar and different from the human medical field. And the first of these is overdiagnosis. This is a concept and a problem in medicine that is receiving a lot of attention in the human field. There are conferences that have been going on for several years now dedicated to talking about overdiagnosis and trying to minimize it. There are features in JAMA, the British Medical Journal, many other medical journals that specifically talk about overdiagnosis and how to avoid it. As you know, there is the Choosing Wisely initiative, which is widely adopted around the world and is a system for trying to help physicians and patients avoid low value or unnecessary tests and treatments. This is essentially the sum total of the literature on overdiagnosis in veterinary medicine. It's a commentary that I wrote a few years ago for one of the journals in the United States. As I think was mentioned earlier, veterinarians often have never even heard of the concept of overdiagnosis. And so we're not doing very much to try to avoid this in veterinary medicine because it's not a concept that has reached our field yet. As I said, overdiagnosis is correctly diagnosing a disease that a patient has, but that is not going to be clinically significant. So if we test an asymptomatic patient, we may find a disease that's never going to result in any important symptoms or death. Or, as is often the case in human medicine, if we expand our definition of disease, we change the cutoffs for particular tests, we may declare some individuals as having a disease who previously would have been considered normal, but they're still asymptomatic. And then finally, we will often find incidental lesions through imaging or other tests that may not have any clinical significance. So we've diagnosed these patients correctly, but we haven't actually diagnosed a disease that's ever going to matter clinically. Now, overdiagnosis is very different from misdiagnosis, from incorrectly diagnosing something. It's also obviously not diagnosing disease in patients who do have clinical symptoms because then the disease is clinically important. So overdiagnosis is difficult because it's impossible to know whether we've made a diagnosis that's not going to be clinically significant at the time that we make it. We can only know in retrospect. If, for example, we diagnose a disease and the patient chooses not to be treated and never develops clinical symptoms, we can say that was an overdiagnosis. But that's not a very effective way of knowing whether our diagnoses are useful or not. So what we typically do is we use epidemiologic or population data to decide whether or not we have diagnosed somebody excessively. We've committed an overdiagnosis. This is an example from Gilbert Welch's seminal book on overdiagnosis, which shows one way that this can work. We look at the incidence and mortality data for a cancer, for example. And if we introduce a new diagnostic test and we see an increase in the incidence of the disease, we also see an increase in the death rate from that disease, we can say that that very likely is a true increase in incidence because we're seeing more clinically significant outcomes. But if we introduce a new test and we see an increase in the diagnosis of a disease, but we don't see any increase in the clinical symptoms or in the mortality outcome, then we may be overdiagnosing. We may be diagnosing cases of that disease that are never going to progress to be clinically significant. The classic example of this that's often given is the use of prostate-specific antigen to diagnose prostate cancer. When that screening test was widely adopted in men without clinical symptoms, the incidence of prostate cancer diagnoses increased significantly. However, the death rate did not increase, and it was later determined that many of those cases were going to be non-productive. They were not going to develop into clinically significant disease. So that was overdiagnosis. So how common is overdiagnosis in veterinary medicine? What does the epidemiology say about this problem? Unfortunately, we have no idea. There simply is no data on the incidence of overdiagnosis in veterinary medicine because it's a concept that isn't discussed very often. I'm just going to make a little adjustment to my light here. There we go. Okay. So why is overdiagnosis a problem? Well, it's a problem because if you're diagnosing disease and if you were then treating that disease and it was never going to be important clinically to your patient, then that is a poor use of healthcare resources. It increases the costs of those resources. It increases harm to patients. Men who are diagnosed with prostate cancer have an increased incidence of cardiovascular events and of suicide simply by getting that diagnosis. So if that disease is not something that we can effectively treat, then there's no benefit to those patients from that diagnosis. In veterinary medicine, we also have an additional problem, which is economic euthanasia. Veterinary patients who have treatable diseases are often euthanized because the owners do not have the financial resources to use those treatments. So if I am spending resources diagnosing clinically irrelevant disease, those resources are not then maybe available for needed treatments for those patients. And those patients may end up being euthanized rather than treated because I have used my resources inefficiently. So that's one of the potential dangers of overdiagnosis in the veterinary field. In human medicine, we have a lot of data about how much overdiagnosis costs in a financial sense and what it does to the cost of healthcare. These are just some examples from individual papers looking at things like mammography or the treatment of low-grade hypertension and how much money is spent on diseases, either diagnosing or treating them, when those diseases are not clinically significant and don't affect important measures of outcomes such as morbidity or mortality. There is a lot of wasted resources in the human healthcare field. Once again, what is the cost of overdiagnosis in veterinary medicine? You can all guess that the reality is we don't know. This is not an area that's been studied at all. So why does overdiagnosis happen? It happens for the same reason that all of the errors in medicine happen, because of how human brains work, right? There are a number of cognitive biases that lead us to make overdiagnosis. We have a very strong need to take control of our health as individuals, so we are always seeking diagnosis. We have a notion that diagnosing people at an earlier stage of disease is always beneficial, when in fact that's not true. As clinicians, we can all come up with anecdotes of cases where we diagnosed a patient early and were able to save them, when if we had not run a test, we might not have been able to save them. And that anecdote creates a sense that testing is always appropriate and always beneficial, even though it's not true. Overall, these psychological factors are a big part of why overdiagnosis still exists in the human field, even though we're aware of the costs and the harms associated with it. In veterinary medicine, we also have the issue of a significant lack of evidence. We don't know how common overdiagnosis is or when it's occurring, so it's very difficult for us to avoid it. There are also financial factors. Diagnostic tests are a source of income in veterinary medicine, and telling veterinarians to do fewer diagnostic tests might in some cases be resisted for financial reasons, and we have to take that into consideration when we're educating veterinarians about overdiagnosis. Some people will argue that overdiagnosis is less likely in veterinary medicine than in human medicine, and there are a couple reasons for this. Our patients cannot report their symptoms, so when I see an animal who's clearly ill to me, oftentimes the owner doesn't realize that that pet is ill. So to some extent, testing animals who don't have obvious symptoms or symptoms that are recognized by their owner may be more appropriate and less likely to lead to overdiagnosis because of the problem of our patients not being able to tell us when they have important symptoms. We're also in a business that is what we could call fee-for-service. We don't have much health insurance in our field, so my clients have to pay specifically for each test that I run. So oftentimes I'm less likely to run diagnostic tests because of financial limitations. This might make it less likely for veterinarians to do unnecessary or excessive testing. We also are less likely to do testing just in order to avoid the threat of lawsuits, because litigation and malpractice is not a real significant problem in the veterinary field. On the other hand, there are some ways in which overdiagnosis may be more likely in veterinary medicine than human medicine. And one of the big reasons is we simply have no idea how often it occurs. There's very little evidence and there's very little awareness of this problem in our field. So clearly we can't avoid a problem that we don't know anything about. There's less use of evidence-based medicine and less use of research evidence in guiding clinical practice, which may encourage overdiagnosis. Veterinarians are free to engage their cognitive bias and to practice in ways that are not limited by research evidence, and this may make overdiagnosis a bigger problem. Similarly, there's a lot less regulation and, as I mentioned earlier, a lot less influence from the insurance industry on what tests we choose to run or we don't run. An example that I use frequently of overdiagnosis in the veterinary field involves pre-anesthetic blood testing. There are few research studies looking at whether healthy patients with no clinical symptoms who are having elective surgeries may benefit from having a CBC or a chemistry panel or a urinalysis run prior to anesthesia. Most of these studies find that in healthy veterinary patients, if you run diagnostic tests like this, you will find abnormalities, but those abnormalities are almost never clinically significant. They don't impact the safety or the morbidity and mortality associated with the anesthesia or the surgery, and in general, there's probably no benefit to veterinary patients who are healthy in running these kinds of tests. And many preoperative blood tests like this in human medicine are actively discouraged by choosing wisely and in other areas where it's clear that there is no benefit to the patient. Despite this evidence, however, it is widely understood in veterinary medicine that running preoperative blood testing is mandatory and is considered good practice. Veterinarians will often, in influential journals and other trade industry magazines, write editorials arguing that if we are not testing all of our patients prior to anesthesia, we're not practicing good medicine. So there's a disconnect between the evidence and the practice that very likely leads to overdiagnosis. These are results from a survey of a little over 2,000 veterinarians in an online veterinary forum, asking the question of at what point prior to anesthesia do you recommend pre-anesthetic screening in healthy patients undergoing elective procedures? And what I like to emphasize here is that most of the data show that people choose to do this testing at certain times, maybe a week before, 3 months before, 6 months before. Only a very tiny percentage of veterinarians actually do not require pre-anesthetic blood work in healthy patients. So again, we are doing testing that has been shown not to have benefits and very likely is an example of overdiagnosis in our field. Finally, I want to give one more example of the relationship between evidence-based medicine in the veterinary field and how it may differ from human medicine. And this is the case of the placebo. It's generally believed that placebos are not relevant to veterinary patients, and that's actually not true and something I find very interesting that I want to share with you. So what is a placebo? A placebo is simply an inert intervention, something that has no meaningful specific physiologic effect, but that creates either a benefit or at least the appearance of a benefit in patients receiving it. Another way of looking at a placebo is it is something that is used in clinical trials which is associated with improvements that are not due to any specific physiologic activity from the placebo. How do placebos work? In most cases in humans, we believe placebo works through psychological mechanisms, through expectation and belief. If you tell someone who is in pain that you are giving them a pain medication, even if you are giving them a sugar pill, they will often report subjectively feeling less pain. So their expectation of benefit from the treatment creates at least the perception of improvement. There are possibly other mechanisms. There's some talk about the role of endogenous opioids and endorphins or of psychological conditioning effects. But in general, we think of the placebo as working in terms of psychological mechanisms. And this is why we tend not to think that it's relevant to veterinary patients, because obviously my patients, the dogs and cats that I treat, don't have expectations about the benefits or the effects of the treatments that I give them. There are other factors, however, that can create placebo effects, particularly in clinical trials, that have nothing to do with psychology. For one thing, if I see a patient who has clinical symptoms of a chronic disease where the symptoms come and go on their own time, oftentimes any treatment I give may appear to benefit that patient because of regression to the mean, because of the natural course of disease. So people don't bring me their patients when they're well, they bring me their pets when they're having clinical symptoms. And if those symptoms come and go, I'm likely to see improvement after a visit, even if what I'm giving them is not an effective therapy. Placebo effects are also apparent in the fact that when someone is participating in a clinical trial, they're often getting better overall medical care, closer monitoring, they're often complying more effectively with other treatments, and so the placebo will appear to improve because the patients will get better even though they're in the placebo arm of a trial, for all of these other false placebo reasons. So what evidence do we have of placebo effects in veterinary patients? We actually have pretty good evidence. There are clinical trials showing significant improvement in dogs and cats and horses who are receiving placebos for measures of pain, for measures of pruritus, for anxiety behaviors, and even for seemingly very objective outcomes like seizures. You see improvements in seizure frequency in dogs who are getting placebos in clinical trials, and that's often surprising to people. This is sort of the classic paper showing placebo effects and probably the most important mechanism of placebos in veterinary patients. And that's what's called the caregiver placebo. The bottom line here is that my patients do not tell me how they feel. Their caregivers tell me how my patients feel. And so placebo effects can work on owners even if they're not working directly on the patients that I'm treating. This was a study looking at dogs with osteoarthritis and measuring their lameness when they were either given a non-steroidal anti-inflammatory drug or a placebo. And in this study, the lameness was measured both through subjective mechanisms, what the owner or the veterinarian assessed the patient to feel, and also through a fairly objective measure, something called a ground force plate, where dogs are walking across a device that measures their weight bearing and assesses objectively whether they're improving or not. And in this study, the authors defined a placebo as a fake medical treatment, a sham intervention that caused caregivers to see improvement where there was actually no objective improvement. So if the owner or the veterinarian reported that a dog was walking better on a placebo, but the objective measurement of their weight bearing didn't show any improvement, that was seen as a caregiver placebo effect. So in this study, over half of the owners reported improvement when there was actually no objective improvement in dogs getting placebos. So it was a very powerful effect. And veterinarians like to think that we're more objective than our patients' caregivers, but the reality is that nearly half of veterinarians reported improvement in their exam findings in patients getting placebos, even though those patients didn't improve objectively. So the caregiver placebo effect is the major way in which patients appear to get better when they're getting treatments that aren't actually effective. A similar study has been done in cats with essentially the same outcome. Cats given placebos are seen by their owners and their veterinarians as doing better even when they're not actually getting a drug. And the same placebo effect was seen. However, there was an additional kind of placebo effect, which I find really interesting. Rather than the caregiver placebo, where the improvement isn't actually happening, but it's seen to happen by the owners, there was something called a placebo by proxy. This is where a patient was receiving a placebo and actually showed objective improvement on objective measures of outcome, even though they weren't getting a therapy. And what we think is happening here is that when owners are involved in a clinical study, they're doing things that actually can improve the condition of their pets, even if the pets are in the placebo arm of the study. They're taking better care of them, they're dropping their weight, they're adhering to other therapies, they're going in for visits more often. So a placebo can actually generate real improvement indirectly through changes in the behavior of a pet's owner. Again, in this study, a large proportion of the patients on placebo showed some improvement, either improvement that wasn't objectively verified, as in the caregiver placebo effect, or even improvement that was objectively real, but that had nothing to do with the placebo therapy they were getting. Finally, just to quickly point out that not only for subjective measures of pain, but even something like objective measures of seizure occurrence, we see this placebo effect in veterinary clinical trials. This was a study looking at a couple of different research studies on therapies for epilepsy in dogs. And what they found is that seizure frequency decreased significantly in animals on placebo. But that was associated with some of the factors of the methodology, and it probably involves these non-specific clinical trial effects. Dogs who are in clinical trials are getting better care, and they get better even though they're on the placebo arm. So placebos are very important in veterinary medicine, even though we tend to think of them as something that isn't relevant to animals. They may be important because of human effects, because of false placebo effects, or because of these other kinds of factors that make animals getting ineffective therapies look better. So why is this important? Why do we care? I care as a clinician because it means that if there is a caregiver placebo effect, my owners may be reporting improvement when the patients I'm treating actually aren't getting better. And this I commonly see with things like glucosamine. This is a supplement that's given to animals to treat their arthritis. And there's pretty good, robust research evidence that it doesn't have any meaningful objective effects on arthritis in dogs and cats. But when I give it to owners in the past, or when they get it for themselves somewhere else, they very commonly report that their animals are better. And I used to have to say, well, if you see them getting better, I can't argue with that. All I have is this research study showing it doesn't work. But now I can say, that's an example of a caregiver placebo effect, where you're seeing what you hope to see. But if that's true, it means that the animal is still in pain and we're not effectively treating them. So placebos are important in veterinary medicine because they can lead us to use ineffective therapies that aren't actively helping. We also need to bear in mind when we do research in veterinary medicine that we have to design our research in a way that takes this into account. If you see a study in veterinary patients that doesn't involve good blinding, good placebo controls, you have to be very skeptical of that because there are actually placebo and other non-specific treatment effects. In clinical practice, as I said, it's very important for me to know that ethically I have to have objective evidence of the effectiveness of my treatments, or I may not be treating patients properly. The bottom line for all of this, I think, is that evidence-based medicine applies in both the veterinary and the human fields in very similar ways. There are some differences in the way that we interact with our patients and in the kinds of resources and evidence we have available. But the same principles apply as you guys are used to using in human medicine, and I think they're useful for all of us to think about. I'm happy to take any questions or discuss any of these issues, whatever you'd like. And I will stop sharing my screen now.
So, yes, I can see you now. Thank you so much, Dr. McKenzie. An amazing lecture. I regret I didn't attend to your lecture when I was a med student because, as you said, it's very similar to human medicine, and it was a comprehensive recovery of basic concepts regarding EBM. And I must admit the caregiver placebo effect is fascinating for me. I never thought about something like that. Very interesting.